for giving me this opportunity to welcome Dr. Hanif. Dr. Wasim Hanif is a professor of diabetes and is one of the beautiful orator. How much is too much? The ideal BMI for an Indian discussion is being taken up by Dr. Wasim Hanif from UK. He is the professor of diabetes and endocrinology, head of the services in diabetes, Birmingham. He is the honorary professor of medicine at University of Warwick and visiting professor at Birmingham. He is a well-known authority in the world of diabetes, and that too with a real-world evidence, working on big data with a dedicated bioinformatics. He is involved as a chief and principal investigator in several international multi-center trials. Professor Hanif has been involved at a parliamentary level to advise the government to issues on public health as well as the ethnic health. He is on the board of governors as a trustee of diabetes in UK, one of the very important personality in UK. He is the chair of the diabetes working group of the world recognized South Asian health. For that, he is a member European policy and big list of his achievements. He is being involved in many international and national papers that include IDF, WHO Global Policy, Commonwealth to guide ministers at UN Summit, chair International Advisory Board. So a lot of achievement to his credit. He is an international personality and we are pleased to have him here. Dr. Wasim Hanif will be talking on how much is too much. So I think this is nothing too much. Right, Dr. Wasim.
Thank you. Thank you very much, Dr. Gomba. Can you see my screen?
Yeah, we do. I'm saying.
Okay.
Yeah,
sir,
but
please share your
got a very good personality now.
Are you able to see my screen or?
No, yeah. Sir, please share your screen, sir.
We are.
So there is a green icon, share screen. Yes.
Yeah. Are you able to see it now?
Yes, sir. That's better.
Cheers. Thank you very much, Dr. Gomba, for your kind words, and thank you, Amit, for chairing the session. And I would like to thank the organizer, especially Dr. Sabu, for inviting me. Now, what I'm going to be talking today is to try and take a little bit of muster out of this thing about how much is too much, an ideal weight for an Indian. The reason I'm going to be giving this talk is because I was kind of involved from Diabetes UK and other things in the direct study. And as you know, the direct study and the remission of type 2 diabetes has become extremely topical globally. And I think it's a very, very important issue. Now, one of the main principles of direct study was to help patients lose weight, 10 kilograms, 15 kilograms, and that causes remission of diabetes. So beautiful study showing a huge amount of weight loss can cause remission of diabetes. Now, when this study was actually is now being implemented across the UK in a NHS diabetes remission program. Now, one of the questions that was asked was that what should be the weight for an average South Asian to be referred into this program. And we were actually planning a study called Disha, which actually wanted to find out how much is too much, as to what is the BMI for South Asians at which they increase the risk of diabetes. So what I'm going to be focusing more on BMI is based on the glycemic effect of overweight or obesity. Now, before actually I start my talk, let me just take you a step back and show you a paper which I did with my very good friend, Professor Kunti from Leicester. And this was basically looking at the representation population of people of South Asian origin in major cardiovascular outcome trials that we have all been talking about and trying to implement. And what we found were 12 studies. And we found globally South Asians, and this is not Asians, I'm particularly talking about South Asians. So these are the people from Indian subcontinent, were grossly underrepresented. So although these clinical trials may have an effect on all population, we need to go with a kind of visor that the South Asian populations have been underrepresented. Now, this is again a very good quote from Salem, who's well known. And he basically has got this thing about obesity is a normal response to an abnormal environment.
Everyone.
And this is so true. So what we are seeing is when we talk about overweight and obesity, for the first time, we are living in an environment where we have got calorie excess in the whole of the evolution of the humankind. And that is leading to obesity. Now, the question is, what is a normal BMI? Now, normality in any situation is actually defined by measuring the mean of the population with 2 standard deviation. But somehow what has happened in the last 50 years or 70 years in the Western countries, and that's now what's happening in the emerging economy, is that the mean or the median has actually shifted. So let's look at some of these numbers to find out what is the normal BMI. So the median BMI of newborns in the US is around 13. Adult males in 1900s in the US was 21. In median BMI in rural Bangalore is still 19.5. So what we are seeing is a huge thing, but we still consider a BMI of 25 to be normal. But before we actually start looking at obesity, we also need to know the importance of underweight or undernutrition and the effect it has both in terms of morbidity and mortality. And this brings up to what you call the J-shaped curve of obesity. What it actually shows is the ideal BMI is somewhere between 18.5 to 25. Anything below that or above that increases the risk of dying. So it's a very kind of a narrow escape that, or a narrow margin that you need to have your BMI within range. Now let's look at the definitions for obesity, and you're all aware of it. Underweight is 18.5, normal weight is 18.5 to 25, overweight greater than 25, less than 30, and then you've got obesity, class 1, 30 to 35, class 2, 35 to 40, and class 3 is above 40. Now, there have been definitions both by the Royal College of General Practitioners, South Asian Health Foundation, as well as the International Obesity Task Force that have seemed to define obesity in Asians as BMI greater than 25 and overweight as greater than 23. Now, when we talk about the sequel of obesity, we talk about a lot of things. Now, most of these sequelae, be it pulmonary, gastrointestinal, obstetric, or musculoskeletal, these usually tend to happen in people with a BMI greater than 30 or 35. So you need to have a lot of weight before you starting seeing these sequelae. But when it comes to metabolic sequelae, and especially this is probably different in a South Asian context, these sequelae tend to happen at a much lower BMI. So it is important to differentiate the two. Now, this is a very famous picture. I always say to Professor Yachinek that if he got a pound every time this picture would have been shown, he would be $1 million now. But the point here is to show that South Asians per se tend to carry more body fat compared to the same BMI in white Europeans. Now, this is a study which we actually did with, and this is a population from Leicester comparing South Asians with white Europeans. And here what we were looking at is only a single determinant. That is your risk of developing type 2 diabetes or hyperglycemia, not other sequelae or complications of diabetes. And what this study showed was a BMI of 30 in white Europeans corresponds to a BMI of 22.6 in South Asian males. So you could see once your BMI crosses 22.5 in a South Asian, your risk of diabetes, developing diabetes, is as high as a white Europeans with a BMI of 30. Now, this is a paper which we did basically based on the thin data, basically comparing the BMI for people with type 2 diabetes based on their ethnicity. And what we found in this very large study was South Asians had a lower mean BMI when compared to white Europeans or even Afro-Caribbeans, again, suggesting a point that South Asians develop diabetes at a much lower BMI. But what was also interesting in this study was that when you look at grade 3 obesity, that is BMI greater than 40, or grade 2 obesity, BMI greater than 20, the representation population of South Asians is much lower, which basically means that South Asians per se don't become very obese, but once the BMI reaches about 30, 35, they probably, the beta cells fail and develop diabetes and stop gaining weight. So there are very few South Asians that we see in our clinics with a BMI greater than 40 or 45 or 50. The ones that are there are usually people who have got short stature. So they carry a huge amount of weight when compared to white Europeans or Afro-Caribbeans. And this is something very important because it helps us to understand why South Asians don't become grossly obese. Now, this is a very interesting paper, and this is a concept I'm going to be talking about a little bit more. This is from Venkat's group from the US. And what he actually is the question about when you talk about diabetes prevalence based on ethnicity, and you look at normal BMI, overweight, and obese, what is shown is that when you look at the people of the Indian subcontinent, they usually tend to be mostly represented in what you would call normal weight BMI. So the normal weight BMI with type 2 diabetes is a very interesting concept, and that is perhaps different from a conventional understanding of obesity and type 2 diabetes. Now, this is another paper of ours where we actually looked at the mean BMIs, and this we looked across the age groups comparing white Europeans and South Asians. And what we have found is that the relationship between BMI between white Europeans and South Asians tends to become more blurred as they age. So what it means is in elderly South Asian population, they tend to develop diabetes at a much, much lower BMI than white Europeans. So as South Asians get older, the risk of developing diabetes with normal weight BMI actually tends to increase. Now, one of the most important things that we have somehow made to understand is type 2 diabetes and obesity is very much linked, and it is all has got to do with weight. This might be true partly, but not entirely true. So when we look at the genes that kind of mark for obesity and those for type 2 diabetes, there is a lot of discordance. There are only about 2 or 3 genes that have got a concordance with obesity and type 2 diabetes. In general, there is a bit of discordance. So what is about the South Asians that makes them develop diabetes at a lower BMI? Now, this is a hypothesis that has been suggested by a number of people, and this has got to do with 2 things. The first is it has got to do with the adipocyte cell size. So in South Asian, the adipocyte cell size is much larger when compared to white Europeans. So this is what we would call a hypertrophic adipocyte. So the fat is stored in a single adipocyte that tends to grow in size. The Europeans tend to have a smaller adipocyte in terms of diameter. So this is what we call a hyperplastic adipocyte. So the Europeans may have a lot of adipocytes, but of small size. So why is this important and what it leads to? So this means the envelope or the subcutaneous storage of white Europeans is much larger than that of the South Asians. And because of that, we have what we call the co-defect or the fat overflow hypothesis. Because the South Asians are not able to have a lot of subcutaneous fat in their adipocyte, the excess fat tends to overflow, and it tends to deposit in the visceral tissue and in the liver, causing all the consequences of diabetes, right from insulin resistance to hyperglycemia, increase of FA, atherosclerosis. So the co-defect perhaps is in the fat storage in the South Asians, and this fat storage deposit may also lead to beta cell dysfunction. So why are we seeing this amount of diabetes in a South Asian context? And is this type of diabetes is different? And do we need to target something else other than just obesity? Now, this is a paper that was published in Diabetic Medicine. And this basically looked at people who were underweight, normal weight, and overweight with type 2 diabetes, and looked as to what was the factor that was driving diabetes in this population. Whether it was insulin resistance, this was measured by the C-peptide, or insulin resistance was measured by HOMA, or was it the beta cell dysfunction that was measured by C-peptide? And what it found was that when it came to underweight and normal weight, it was not the insulin resistance, which was pretty much the same, but it was the beta cell dysfunction that was driving the diabetes. And this is something which is very, very important and has been neglected for a very long time in an understanding of type 2 diabetes and obesity from a South Asian context. There have been a number of publications from various groups, and these have all shown the evidence of reduced beta cell function in Asian Indians with mild dysglycemia, beta cell function being the most predominant factor in Asian Indians, even at the stage of pre-diabetes. So there have been a lot of publications coming in this area. And we also see that if you look at the HOMA insulin resistance as it tends to develop, the beta cell dysfunction in an Asian Indian context tends to develop even with mild dysglycemia, which is not something we see in the white Europeans. They tend to develop beta cell dysfunction at a much later stage. So even with mild dysglycemia, you're seeing a reduced beta cell dysfunction. So this brings to me this very interesting comparison about the tale of two Indians. So our conventional understanding or the Western understanding of type 2 diabetes is pretty much based on what we call the Pima Indian model. Now, there have been lots of publications from Professor Mohan's group and others, which is looking at what you call an Asian Indian model or from Chennai. So the prevalence of diabetes in the both group above 55 years is very high, greater than 50%. But the obesity profile is different. The Pima Indians is very obese. The Asian Indians is relatively thinner. If you look at the glucose profile, it is higher 2-hour plasma glucose in Pima Indians, while Asian Indians, it's the fasting plasma glucose. Pre-diabetes, 2/3 pre-diabetes are IGT in Pima Indian, while in Asian Indians is IFG. And insulin resistance is 2 to 4 times higher in Pima Indians when compared to Asian Indians. And if you look at the insulin secretion of beta cell dysfunction is much lower in the Asian Indians. And this is shown when you look at the diabetes prevention study. So if you look at the DREAM study with rosiglitazone, what we find is that the effect of rosiglitazone in terms of reduction of diabetes is much higher in people with normal BMI. And this is even shown when you look in the Indian cohort of the DREAM study, the effect of rosiglitazone was much higher when compared to the others. And we see similar data from the Indian diabetes prevention study, where the effect of metformin is same as that of the lifestyle. When you compare to the others, where lifestyle has triumphed over this thing. So what we are seeing is that if you look at the BMI subject with IGT and DM, we're seeing that those who went to develop diabetes became obese relative to themselves, not to others, but relative to themselves. And those who went on to develop diabetes also have poor beta cell function. So it's the combination of the two that is very important. The other important thing is that when we give advice in terms of weight loss to a South Asian patient, one of the things that we really forget is the importance of grip strength. So when these people who are relatively normal weight or slightly overweight by definitions, if they usually lose large amount of weight, they tend to lose the muscle mass. And that muscle mass loss is something we need to be quite aware of before we set the targets, because the grip strength there seems to be a direct relationship between the grit strength and the risk of diabetes, especially in a South Asian cohort. And similarly, as we know, when it comes to physical activity in this, they have to do more physical activity to minimize the risk of diabetes. Now, one of the other things is that where this is all leading to, and this is very famously said, we are what we eat. And this is a very interesting data from SHARE study, which actually showed when you compare to even Chinese, the South Asians tend to have a large amount of carbohydrate load. And this is something, again, that needs to be looked in, and a very little intake of protein. So it's this imbalance of diet with high carbohydrate and decreased protein. Now, this has been talked a lot about remission of type 2 diabetes. Is it possible? And we know the answers, and this data was actually shown in the earlier talk as well. But really the question is that if we have got an Indian person with a BMI of 25 or 23, are you going to put him for diabetes remission? And if you are, how much weight loss are we going to make them lose? So these are some of the questions that are still unanswered, and we cannot forget the importance of beta cell dysfunction. This becomes even more important when we recommend patients for bariatric surgery, and there have been various BMIs suggested for bariatric surgery in the UK for referral for South Asian patients. Some have even suggested a BMI of about 27. Now, one of the real difficulties is that when you're trying to set these guidelines, what we find is there is very little data. There is very little data to actually show at what BMIs these interventions should happen in a South Asian population. And this is something very important. Now, most of our guidelines are actually coming from a context of research that is being done in a white European or Western concept, which may not be entirely suitable for a South Asian cohort, and especially in this case where maybe even the pathogenesis of diabetes might be different. This comes to my thing about what I call the heterogeneity of type 2 diabetes. One is increased metabolic load, which is decreased insulin action, adiposity, physical inactivity, 2-hour glucose, lifestyle, and metformin. This is seen in Pima Indians. Decreased metabolic capacity, decreased insulin secretions, could be a lot of factors, lifestyle, and this is Asian Indians. And this brings me to the last two slides. So why are we seeing this? So this is the world population in the map showing you the greatest bulges where the greatest amount of people live. And this is the prevalence of diabetes, and you could see that the big bulge in the Indian subcontinent. And this is the number of publications that decides our thing, which mostly come from the Western world. So on that note, I'm happy to take any questions, and thank you very much.